Hello, everybody, and welcome to Thriving Autistic's first webinar with huge thanks to EDS Support UK for joining us and co-hosting this event. If you'd like to follow us on Eventbrite for any further webinars, we're hoping to provide these support webinars once a month or so. We would be delighted. And I'm going to hand you over right now to our hosts, Jasper and Sarah. Thank you.
Thank you, Tara. So today we're here with EDS UK, Sarah as well. So before we kind of start, we thought it'd be good to just sort of explain how we're kind of going to run today. So we're going to start with just introducing who we are and explaining a bit about EDS UK for those of us from Thriving Autistic and Thriving Autistic from those from EDS UK. Then we'll go into a bit explaining what EDS and the kind of related conditions are, briefly explaining what autism is, and then going through the diagnostic criteria and some tips on, communicating pain and advocating for yourself. And then if we have any time, we'll try and answer some questions. Right. So my name is Jasper. I use he, him. And my main diagnosis is hypermobile EDS, although I have quite a lot of the related conditions as well. I'm formally diagnosed as autistic and I'm deaf as well. So I am based in Newcastle, the northeast of the UK, and I have 2 degrees from Bangor, Wales, not Ireland. First was in psychology with neuropsychology, and my second was an MSc in clinical neuropsychology, and my focus was on brain injury. So now I have a freelance contract with Thriving Autistic, so I do work helping clients with benefits. So this includes PIP, mostly for those in the UK, and disability allowance for those in Ireland. But I also do some self-employed accessibility work, so delivering training, workshops, that kind of thing. And I also volunteer in my free time with EDS UK as an area coordinator. So I run the support group based in Newcastle. I'll hand over to Sarah.
Brilliant, thanks Jasper. Just to let everyone know, this will be recorded as well, so you can come back to it. So if anybody wants to flick their cameras off, you can do so. My name's Sarah, she, her. My diagnoses are hypermobile EDS and basal vagal syncope, very similar to POTS. I'm based in Oxford in the UK. I have a BSc in psychology as well as a PG DIP in brain injury rehab from Birmingham University. I'm the Advice and Information Manager for EDS UK, previously in the Communications Manager position. And I've been there about 6-7 years now. And I previously managed supported living services for the National Autistic Society.
It's going to change. There we go. So Thriving Autistic is a not-for-profit social enterprise, and we support adult autistic folk, the whole kind of community. And so we follow the kind of disability movement motto, nothing about us without us, which means, really we want those who, you know, identify as autistic to be running things about autistic people. So all our directors and practitioners are either autistic or neurodivergent themselves, and we offer accessible, low-cost coaching and group support. We do community webinars like this, as well as training in both mental health capacity and work in the workplace too. So that's just a bit about Thriving Autistic. Oh, did I miss you, Sarah? No, I didn't. Okay. So autism, very briefly, is a lifelong neurodevelopmental disability, which basically means it's present from childhood. It's even if you get diagnosed later, it's likely your symptoms started when you were young. So kind of approximately in the hearing community, so those who can hear, 1 in 100 people are autistic, and those in the deaf community, it's about 1 in 76 people in the UK. So like lots of conditions, it's a spectrum condition, which means every person is affected in different ways, different symptoms, different situations. But generally speaking, it affects communication and interaction. So relating to the people and also communicating with others. So that can be things such as not speaking at all, or only in certain situations, which is kind of called selective mutism. Maybe needing longer to process information or thoughts, and potentially struggling with things such as eye contact, facial expression, sarcasm, and small talk, as well as sometimes having difficulty being around lots of people, particularly if they're unfamiliar to you, which can lead to exhaustion, as well as, you know, difficulty with change and having a heightened sensitivity to the different senses, such as sound, light, that kind of thing. But the main 3 criteria to get a diagnosis is difficulty with communication and interaction, repetitive behaviour or special interests, as well as symptoms starting from early childhood.
Hi, EDS UK, and a bit about the Ehlers-Danlos Support UK. So we are a UK-based charity, and we provide support for the EDS and HSD community, and we're involved in a bit of research and awareness as well. Our vision is that nobody should be left to fight on their own. So every person with EDS or HSD, should have access to appropriate medical services, care, and management in place. We work to improve quality of life for people living with EDS or HSD, raising awareness both within the medical community and the general public, and providing support as part of a growing community. Our 4 areas of focus are education and awareness, support for those affected by EDS, so this includes family, friends, and individuals that have the condition themselves, better knowledge through research, and organisational capability to make sure we're a high-performing, sustainable organisation. Our focus is EDS, but we welcome anyone whose symptoms cross over, and who we can tell till beginning of their journey suspecting hypermobility, all the way through to management after that. So what are the Ehlers-Danlos syndromes? They are a group of connective tissue disorders. It affects the entire body, with the main symptoms being joint hypermobility, chronic pain, chronic fatigue, and issues with organs. This mainly refers to the most common type, which is hypermobile EDS. There are 14 different types, and everyone can be affected differently, even within families. Sister to brother can have different symptoms from the same condition. Oh, nearly missed a point off the end there. EDS can change day to day as well. So one day a wheelchair might be needed, another crutches, another day might be able to get around without a mobility aid. So it's a fluctuating condition.
Yeah. So currently, there's not really much research into the area of EDS and autism. So we don't want to kind of give some sweeping generalizations of what we think, because the truth is we don't really know yet. It is likely that there is a link. So research has shown that people who are diagnosed with EDS have shown to be autistic, compared to those who are not autistic. There's more kind of people who fit the criteria in the kind of autistic community. And from our support groups, we can see there is an overlap between the two conditions of autism and EDS. So at both Thriving Autistic and EDS UK, we work to support everyone in the community with their diagnosis, including management, emotional well-being, that sort of thing. And we know that, working together enables us to have a better understanding of, the community's needs and how we can adjust to help that, depending, on the person's access needs, kind of different situations. But as we said, more research needs to be done in this area, as it's not really enough to be totally sure or kind of prove anything with statistics. But we hope in the future more research will be done in this area. And, even in the last year, there's been a lot more recently. But due to the probable link, we think it's important that you know and understand the signs and symptoms of EDS, particularly as it can present slightly different in the autistic population, as well as, understanding how to kind of manage those symptoms. So our belief is that it's important that every autistic person knows that there might be an additional cause to symptoms they are experiencing. Technology is not my forte. There we go.
Brilliant. Wanted to talk a little bit about the difference between EDS and HSD. So classification changed in 2017 and it is a little bit confusing. So what we've got is a spectrum. On one end, you have hypermobility that doesn't cause issues. So dancers, gymnasts, and things that are hypermobile but have no issues with their joints. Then we work in a spectrum to the other end where we have hypermobile EDS, where it's affecting kind of everywhere in the body. It's multi-systemic. In the middle of that are the hypermobility spectrum disorders, and these can vary from one joint affecting you. So it might be that your hypermobility in your shoulder is causing issues and pain, right through to all the joints and beginning to affect organs as well. I'm just going to catch it. So it's a disease. It's not a disease, it's a trait like height. And there are 4 subtypes of the hypermobility spectrum disorders, depending on the joints that are involved. It's possible to be hypermobile in the past and gradually become stiffer with age. Additionally, if you have an injury to a joint, for instance, you may lose your hypermobility in that because arthritis and other such conditions can set in. So HSD are more common than EDS, but it can be just as symptomatic, and the management for both hypermobile EDS and HSD is the same. So patients should still be given the same level of care and management with these conditions. What causes EDS? So EDS affects the connective tissue and collagen within the body. So the collagen is the building blocks, it's the mortar between the bricks, basically. It provides strength and elasticity throughout the body. It's also the most abundant protein, which is why it ends up affecting skin, muscles, tendons, ligaments, blood vessels, organs, and eyes. If there are bad foundations, the rest of the body will be affected. It's going to have a knock-on effect to how things are. Day-to-day symptoms that people experience, so chronic fatigue, extreme tiredness, which isn't helped with rest. This is the kind of fatigue that no matter how much you sleep, it's not shifting. Postural tachycardia syndrome, POTS, dizziness, fainting, low blood pressure, can be triggered by heat, stress, for instance, digestive issues, both loose bowels, constipation, bloating and pain. Anxiety and depression are quite common in EDS and HSD as well. Can be panic attacks, problems with socializing, and dealing with having a chronic illness. Mast cell activation, this is an onset of allergies and reactions to things in the environment, food, perfumes, clothing, doesn't really kind of matter which, it can affect people. Chronic pain affecting both nerves and joints, sometimes one and not the other. Dislocations and subluxations. So dislocations are very severe. A lot of the time people end up in hospital or are able to sometimes manage them and get them back in. Subluxations are the shifting of the joint within the socket that's not fully coming out. Dyspraxia, so that's a lack of spatial awareness, and a lot of children are called clumsy that have HSD or EDS because they have no spatial awareness. And daily changes, some days are better than others, some days are worse. And poor healing, cuts, colds, joint injuries taking longer to heal can have a big impact too.
Great. Yeah, so just before we go into the diagnostic criteria, I thought it would be good just to explain some of the barriers that, kind of prevent a lot of the kind of autistic population actually getting an EDS diagnosis currently. So autistic people are known to kind of find describing particularly kind of internal feelings and sensations a lot more difficult. So this can relate to describing pain, having a different perception or tolerance for it, as well as someone might present in kind of an atypical way to what is outlined in the current clinical guidance, due to these kind of different perceptions, language, communication, and kind of understanding of our experiences. And this can lead to barriers when, trying to seek help, where you need to kind of be articulate in advocating for yourself. But there's also, a severe issue with reasonable adjustments in healthcare, meaning that, those situations where you are at consultant appointment then become a lot harder, and there's already that barrier before even, you know, discussing a potential diagnosis. So this information that we're given is often not accessible to us, not adapted, so we can, you know, find it difficult to even find information about EDS if we can't even really understand what it is. So this leads to, you know, lots of us in the autistic and neurodivergent kind of community then, you know, going to our communities, asking about, you know, do you have similar experiences? You know, these are things that happen to me. Is this an autistic thing, or is this potentially EDS? And kind of, you know, making sure with others that it's a thing before actually trying to go for a diagnosis. But then sometimes we then come across as too knowledgeable and kind of pushing for a diagnosis, for pushing for what they call a rare diagnosis, when actually it's not quite as rare as they think it is. Yeah. There you go.
Wanted to talk a bit about the diagnostic criteria. It can be quite a confusing one for Ehlers-Danlos Syndrome, and it's got lots of medical jargon in it as well that could definitely be simplified and sounds very complicated, but often means something very simple. So we have 3 criterion with regards to the diagnostic checklist. So criteria 1 is the generalized joint hypermobility. And that discusses the Baton score. So the pictures that you can see on the screen, you would get a score for being able to do each of those things. If you're over a certain age, you need a lower score. And additionally, it's meant to be taken into consideration if you were previously able to do these things, but now can't due to age or injury. So if you were able to put your thumb flat to your forearm, but you now can't because you've had an injury to that joint, the point should still be counted. Moving on to criterion 2. So I'm just going to work through these and kind of describe what that means. Some of them are quite self-explanatory, some need a bit more. Unusually soft or velvety skin, mild skin hyperextensibility, stretchy skin. This is something that not everyone with hypermobile EDS has, and it is often then dismissed as hypermobile EDS by doctors because they're thinking of a different type that has very stretchy skin. The unexplained stria dystensae are actually in reference to stretch marks. So this just means unusual stretch marks on the back, groins, thighs, breasts, abdomen, without a history of significant gain or weight loss. So we know that stretch marks can come when you suddenly put on weight or suddenly lose weight. So it's just stretch marks for no reason. The bilateral pyogenic papules of the heel basically means little fatty lumps in jargon. So when you put your foot flat on the ground, you'll see some little fatty bumps come up around the heel. It's normally a sign of a connective tissue disorder. Recurrent or multiple abdominal hernias, that's quite self-explanatory. Atrophic scarring is a scar that can start off as a line and it basically spreads out as the scar heals. And it's different to classical EDS that looks like cigarette paper, very thin. This is more stretched out scars. Pelvic floor, rectal or uterine prolapse in children, men, or those assigned female at birth without having children suffering from these prolapses. Dental crowding, so too many teeth in their mouths, basically, quite often needing braces, and a high or narrow palate. You'll be able to see this just by having a touch of the top of your mouth. I can never say this one, arachnodactyly, probably wrong, but we'll go with it. It's in regard to quite often what is known as marfanoid habitus. And it means that if you have your hand like this and you close your thumb across, your thumb would come out this side. Obviously, my tiny thumb is nowhere near. Additional that your arm span is longer than your height. Mitral valve prolapse is to do with the heart. It will be picked up on echocardiogram. Again, it's a rarer symptom of hypermobile EDS, as is the aortic root dilation. Again, your doctor should refer you for a echocardiogram. Lastly, so family history as well. So meeting the current criteria. A family member doesn't have to have a diagnosis, just the symptoms of. So if they would meet this criteria but haven't been officially diagnosed, that would count. And pain in 2 or more joints every day over 3 months, widespread pain, and dislocations and subluxations. So again, the dislocations are, for instance, a kneecap that has come completely out of place. It'll end up behind the knee or to the side. It causes a lot of stress in the area afterwards. A subluxation is the kneecap shifting, not fully coming out, but it's shifting. You'll begin to weaken things around that area as well. And it's important for, in criterion 3, this basically goes into making sure that it's not something else. So doctors should be thorough in making sure that your symptoms don't match a condition that's similar, and not to kind of ignore symptoms that don't quite fit, to make sure they cover all bases. I won't go into the details of all the other conditions, but it's that they should dig quite deep to make sure nothing's missed. In terms of a pathway to diagnosis, it can be a little bit complicated. Go to the GP, discuss your symptoms, and ask for a referral to a rheumatologist. If your GP is happy to put that through, you get your referral to the rheumatologist. If they are unsure about hypermobility syndromes or EDS, you can ask them to refer you to someone who is EDS aware. You can get in contact with us as a charity, and we'll be able to let you know the nearest person to you for that. If they are aware, fantastic, brilliant, discuss with the management, so physio, if you need further referrals. If your GP doesn't want to refer you, you can ask to see someone else in the practice, speak to the practice manager, or you can get your local health watch involved, and they can help with the pushing through of referrals. Additionally, your local MP as well can sometimes help with these things. If you get really stuck, of course, that's why we are here. So give us a call.
If it lets me change, great, cool. Thank you, Sarah, for going through that. I think that's very helpful. Oh no, it's signed me out. Don't do that. Okay, just a minor technical issue whilst Zoom tries to make me go into a different account, but I think I can try and just remove that. Okay, yeah, so some tips about attending either your GP appointment or a consultant appointment. So one of the first things I recommend is that if you can, try and make an appointment with a GP who kind of already knows you, who you kind of trust. So someone who, you know, in your past, if you've brought up stuff before, has taken you seriously, that's really a good kind of person to go to, because, you know, a bit of your anxiety then reduces. If you can, I also recommend making a double appointment. This means you just have a bit longer to, try and explain yourself, have time to process any information or questions they ask, and you don't feel kind of as rushed rather than trying to kind of blurt everything out in 10 minutes, which, is not necessarily feasible. And if you are struggling to work out who to see, EDS UK, if you are based in the UK, does also have a local kind of friendly doctor recommendations list, which is basically emailing Sarah. So familiarizing yourself with the diagnostic process, which Sarah's just gone through, is really helpful, because often your GP might not know that much about EDS or even the referral process, because still not many people really know about EDS. So it's good to know that what should happen, so that if it doesn't happen, to kind of explain, oh, actually, are you sure that's where I should be referred to, because I think it's actually rheumatology. And as always, try and do some research beforehand, so make some notes before your appointment, so that if you are anxious or you forget something, you can just kind of check your list and make sure you've covered everything you wanted to. So particularly if it's a consultant appointment, I recommend bringing a list of your current medication, as that's something that's often asked. And if you're like me with too many to pronounce or remember, it's good to just kind of show them the list so they can just scan it into their computer, as well as any current diagnosis you have. So for example, you might have something like IBS diagnosed, or POTS, or one of the many conditions linked to EDS. So that just gives them a bit about your medical background, to understand that it is probable that you do kind of meet the criteria. And if you have had any kind of investigations or tests, so for example, an ECG, that helps them have a bit more understanding as well, particularly a consultant, not necessarily for your GP. And obviously, most importantly, the symptoms that you're experiencing. So, you can use the diagnostic criteria to help with this. So that might be, chronic pain, fatigue, that sort of thing, as well as the severity of these symptoms, which I know is a difficult thing, but I'm going to go into that a bit more detail later. But basically, it's be prepared to know that you kind of need to speak the doctor's language, as it were. So they love everything to do with severity. So that's kind of the game we have to play in the medical world. So some tips on actually attending it. So I always recommend that you bring someone with you, whether this is a friend, family member, your partner, support worker. It just really helps to kind of reduce any anxiety, and helps if you need to make a complaint later as well, because then you kind of have a second witness. So I suggest arriving around 15 to 20 minutes early to an appointment, especially if you're unfamiliar with the hospital or the department, as that gives you time to get a bit lost but find the right place, check in and fill in any potential paperwork that they want you to, such as maybe a questionnaire or something like that, as well as just reducing any anxiety about being late, so you have the full time of the appointment, and don't have to worry about missing it or anything like that. And then, so if you have someone with you, it's also great because they can make notes of what happens in the appointment. So, the doctor's name, what happened, that sort of thing. And if you want, you could also consider making a recording of your appointment. So through an audio recording kind of transcription app. I use Otter AI, but I always ask my doctor first for permission, just because no one really likes being recorded without consent. So, maybe just check that it's okay, should be fine. And also means, they're probably less likely to make any inappropriate comments if they know they're being recorded as well. Also, ask for any clarification if you are confused. Medical jargon is really difficult to understand, but your doctor won't know that you don't understand unless you tell them. They can't read minds, unfortunately. And also be prepared that you might be asked to have things such as your vitals checked and potentially have a physical examination, particularly at a GP initial appointment. They might check your blood pressure, your heart rate, and kind of, like around your back. So just be, aware that they might do some of those kind of tests too. And regarding the kind of vital signs and things like that, I find having what they call either a hospital, healthcare, or communication passport can be very helpful. So this is something basically that's made for those who are having difficulty speaking with a medical professional, and it's basically records your medical history, any treatment preference, and also your communication requirements as well. So this means it can help, doctors and staff to understand your needs and somewhat improve their communication with you. So this can include information such as, personal information. So, your name, contact information, and either your NHS number in the UK or your GMS number in Ireland. Who you to contact in emergencies, maybe your partner, family, your medical history, so any medication, allergies, and medical conditions, and potentially something like the discharge procedure. So, if you need advance warning or if you want it done in a quiet room, that's something you can explain there, as well as communication preferences. So, this might be something about booking a BSL interpreter, or it might be, things such as needing the information in easy read, having, a PA or support worker present as well as how you communicate pain and how the doctors should ask you about your pain, particularly if it's different to what is standard, using like the pain scale, that sort of thing. And also any support you would require if you became an inpatient. So, for example, if you had an in-person kind of surgery or procedure and had to stay in hospital overnight, what do the doctors need to know? As well as any support required with medical procedures. So this kind of links to the vital signs. So, with a blood test, can you do that? Or would it be, more accessible to you to have a kind of a thumb prick test rather than, the full kind of injection? With ECGs, is there anything they need to know? How to explain it to you? Same with MRIs, that sort of thing. And there are loads of downloadable templates to help you with this online. I know Thriving Autistic has this, Ambitious About Autism does, as well as other charities like the National Autistic Society as well. And then regarding the actual kind of follow-up of an appointment, So if you're seeing your GP, some kind of good questions to ask are things like, if a referral was made to either rheumatology or potentially genetics, if it's a different type of EDS you think you have, asking kind of for a rough kind of timeline of how soon you should be seen, when you should kind of hear about the referral, and when should you let the GP know if you've not heard anything? When is reasonable to, worry about not hearing anything and kind of chasing it up? And kind of similarly with a consultant. So if you, for example, get the EDS diagnosis, you might be asked to be referred to physiotherapy, maybe pain management, something like that. And again, asking for that kind of time frame, as well as things such as, if they'll send a letter to your GP with your diagnosis with the next steps. And I always ask to be CC'd into this correspondence, because it means I also have that plan. I don't have to worry about waiting for the GP to contact me, particularly if it's someone I don't know or we don't really have that relationship yet. It's quite useful. And then some bits on advocacy. So if you do not have someone who can come with you to an appointment, at least in the UK, you can have someone to come with you called an advocate. Usually hospitals have this, but you can also reach out to organisations if you kind of want to talk to them first. And you have the legal right to this. So, in England and the UK, that is the Care Act 2014 and the Mental Capacity Act 2005 in some situations. So if you need someone because you cannot kind of fully explain your ideas, or, need kind of support to make a decision. In Ireland, it's something I cannot pronounce with my deaf accent, but you also have the Citizens Information Act, which is easier to say, so I'm going to say that one instead. So an advocate is someone who can come with you to appointments or help you communicate with your doctor, whether that be by phone, letter, or in person. So for example, if you had a phone consultation, they can kind of, be added into that call. And depending on your situation and what help you want, there are various advocacy services in your local area. But if you are unsure, you can look online. So, maybe contact Thriving Autistic and see what help they suggest, or, if they have someone who might be able to recommend, what to do, as well as Rethink Mental Illness in the UK. I know is particularly great at this, and there's also other charities as well. So some places that do advocacy include Power, Voiceability. In Wales, there's Advocacy Support Gymrae, and there's Sage Advocacy in Ireland, and MenCap kind of everywhere really. MenCap is for known for learning disability, but they do a lot of work with the autistic population as well. Then also just briefly some kind of healthcare legal rights. So, if something does happen, what your rights are, and if you need to actually make a complaint or anything like that. So they're kind of both the same, the equivalent of the UK and Ireland acts. So the Equality Act 2010 in the UK and the Equal Status Act 2000 to 2018 in Ireland. basically means that you have equal access as a disabled person to use healthcare services. And this is known as making reasonable adjustments or accommodations. So this could be things such as, providing easy read appointment letters or consultation follow-up appointments, having a priority appointment if you find, it difficult waiting in the GP, surgery or hospital for a long time, as well as longer appointments. So if you feel you need more time with the doctor to explain yourself and understand the information that has been given. And yeah, this includes all the kind of characteristics, but most relevant to this is disability, but includes things such as sexual orientation, race, religion, that sort of thing. And then the kind of second main act, again, these are kind of the equivalent of each other. So in Ireland, you have the Disability Discrimination Act 2005, and in the UK, we have the Accessible Information Standard 2016. And this basically ensures that public bodies, including healthcare, are including disabled people, and if requests for help, they do provide that assistance and communicate with a disabled person in a way that is accessible to them. So this might be an interpreter, or it might be providing that easy read information, or using alternative communication technology, anything you need really. And by law, they have to provide this. They have to clearly record this, put it in your patient records, and share it with appropriate services with your consent. So if this hasn't been done, I would, speak to your hospital, your GP, about having this in place. And if they do fail to do this, like Sarah kind of previously mentioned, you can contact the practice manager with these laws, speak to Health Watch, or also PALS, which is patient something.
Advocacy. Wait, no, patient. Oh no, I've forgotten now.
Advisory?
Yes.
Yes, advisory services. Don't know why that went my memory. So they're great for that. And then a bit about the good old pain scale, which notoriously is. Oh, I just find it horrific. I really hate it, and I'm sure lots of us do. Mainly because I cannot relate to these weird smiley and unsmiley faces and what the heck they're supposed to represent. So, when you've become accustomed to, long-term persistent pain, it can be difficult to know how to describe it. And often medical jargon is really quite confusing. So it's quite difficult to kind of express either the kind of intensity or even the kind of specific sensations you feel of the pain that you're experiencing. So often, doctor might ask, on the pain scale between 1 and 10, where do you rate your pain? And this can be quite difficult. My main advice is, asking for their definition. But if you really are struggling with the pain scale, just tell them, say, I feel really unclear of the pain description because I don't really understand it. Could we potentially, talk about pain in a different way, such as through some questions? Because I think I could make myself more clear in that way. That is absolutely fine. You're totally in your right to do that. So kind of before we go into that, I'll just briefly explain what we mean by chronic pain. So it's pain that is longer for 3 months and is persistent. And by persistent, we don't mean it has to be there, every second of every day for 3 months and over. It can be intermittent, so it can come and go. It doesn't have to be kind of always present. And that is, even if you have medication that you've taken, you do your treatment and input such as physio, the pain's still there. It's not going away anytime soon. But there are different types of pain. So this includes things such as nerve pain, inflammatory, musculoskeletal, abdominal, muscle, and joint pain, all which can be quite common in EDS, and it's quite common to have pretty much every time. We like our pain in EDS. So I'll briefly explain what the different types of pain actually mean. So nerve pain is caused usually by nerve damage and can often feel like a sort of like shooting or kind of stabbing pain, sometimes a sort of burning sensation. And, sometimes people, explain it like a sort of like electric shock that's kind of going up and down the body. And it might lead you to feel very sensitive to touch or feel cold more than what is normal to you. So, you might feel sensitive to touch normally, but this is beyond that. So even if, for example, you touch your skin, that would feel painful. And then inflammatory pain is often caused by autoimmune conditions such as irritable bowel disease, IBD, or arthritis, that sort of thing. So this is when the immune system attacks kind of healthy cells and causes noticeable symptoms as well as pain. So things such as redness, swelling, and you might feel kind of, stiff, dizzy, tired, kind of, again, what's more than what's normal for you, especially if, you're moving about or walking, that sort of thing. Then musculoskeletal pain can usually affect the entire body. So it feels kind of like an aching pain, or the muscles feel as if they've been pulled or overworked. And this is usually, again, linked with fatigue, sometimes, difficult to get to sleep, or kind of your sleep pattern routine, being disrupted. And then abdominal pain basically feels like an intense stomach ache. And it's kind of between the chest and kind of pelvic area. And this pain's kind of achy, dull, usually kind of comes and goes, and can be quite sharp pain. So this can be linked to conditions that are associated with EDS, so such as IBS, endometriosis, that sort of thing. And then muscle pain is kind of the muscle tissue. So that's, kind of everywhere in the body. So anything can be affected. And that's usually overuse of a muscle. But there are many different reasons and causes to it. So you might feel like a sort of deep kind of steady ache, or maybe sometimes random sharp pains. Some people have muscle pain all over, and some people have it in a specific area, such as maybe the shoulder, that kind of thing. And then joint pain, probably the one we're most familiar with, which is, usually in the kind of hands, feet, hip, knee, and spine, but it can be anywhere in the body. It can be constant, or it can come and go. So sometimes it feels stiff, sometimes achy, sore, but you can pretty much feel any sensation related with joint pain, and it can affect the function of the joint. So often limits your ability to do kind of some basic tasks. So I've used quite a lot of what the doctors like in terms of describing pain. So I'm just going to briefly explain kind of what those definitions mean. So achy pain is, kind of continuous in a sort of like a certain area normally. And this is kind of a sort of mild, moderate pain. You might describe it as sort of like a heavy, sore pain. So maybe after doing exercise or after your COVID vaccine, maybe. And then dull pain, again, relatively low level of pain, but it might, intensify if you put pressure on it in the area where you have that pain. Raw pain usually affects the skin, so it might, feel sore, sometimes itchy, tender. And then numb pain, again, is generally low level pain, and is usually a loss of kind of sensation and feeling. So it's, that kind of pins and needles feeling, where you kind of briefly feel can't really feel that part of the body. And then a burning is usually a feeling that is extra sensitive outside of what is normal to you. So you might feel kind of that area is hot or cold or painful to touch. That's a kind of burning pain. Then a sharp pain, we're kind of getting up into the intensity now. So it might be a kind of a sudden, intense spike of pain compared to, your kind of baseline pain. And that, kind of fits those descriptors of shooting, sharp pain. And this kind of can occur with a kind of like stabbing pain. So this can occur suddenly and quite intensely. And it can fade away and then reoccur again and again and again. So it's kind of like, I like to think of it as someone's kind of drilling into me. Maybe that's just my weird description. But that's how I kind of think of stabbing pain. And then throbbing pain is a kind of reoccurring ache. So you might experience what they call like a pounding, beating, pulsating pain. So kind of like how your heart contracts is kind of like that kind of contracting feeling, that kind of pain. And then very quickly, I'm going to briefly describe, how you can explain pain to your doctor. So I really, really recommend keeping a diary and record of your pain. And kind of, going through the things that, they are going to ask you, which is, is the pain constant, or, is it always there, or is it worse at certain points in the day, such as in the morning? And can you locate the pain? Is it everywhere in the body, or are there certain places where the pain is even more severe, such as maybe your hips? And then try and rank the pain. This doesn't have to be the pain scale. It can just be, mild is irritating, but I can carry on. Or is it severe? It's really affecting pretty much every part of your life. And then try and also think, is there anything that triggers the pain? Is there anything that makes the pain worse? So, for me, that's going outside and failing to pace and just plowing through the day. That makes my pain worse. And try and also think of the duration of the pain. So is it relatively recent? Has this pain started in the last kind of few years, or has it always kind of been there since, you're a teenager? Try and think back to when you didn't experience any pain, or at the very least when it was, very mild to compared to what it is now. But again, if you are unsure, it's totally okay to say, honestly, I can't remember when the pain started. I've always been aware of it, but since this date, it's got a lot worse. that is absolutely fine. And then
Jasper, sorry to interrupt. Just had a few people asking about the time and things, just because it's gone past 11:30.
Yeah, this is the last slide.
Okay, fab.
So this is just an alternative pain scale that I like to use, because I find having, an actual definition of the different numbers really helpful. Just because it is ending, I won't go through it too much, but this is going to be recorded, and I'll also share my slides. But it's basically kind of categorized into sort of mild, moderate and severe, green, yellow and red. So mild being, it's there, but it's a low level and I can ignore it and get through the day. Moderate is, it's distracting me. I can't do some activities, but generally I'm okay for most of the day. Severe is I really should be in A&E. This pain is horrific and I can't do anything. All I can think about is the pain. And that's, that I won't really go into this too much because we have unfortunately run out of time, but I will provide these slides. But basically, I recommend taking someone with you if you go to A&E, and bring anything that's going to help, such as ear defenders, comfort items, and money for the way home as well. And that is the end, really. Didn't really have time for the questions, unfortunately, but maybe if I ask Tara to share mine and Sarah's emails, and you can always contact us directly.